Hello, you're watching EASDtv. My name's Vivian Parry, and I'm delighted to have with me in the studio this afternoon two people who I think you'll find fascinating. They're going to be talking in a session today about pre-diabetes and remission and what that might mean in terms of global impact. So there's a lot of words there that are going to be triggers for people, I guess. So let me introduce my guest to you, Dr. Birkenfeld, who comes from Tübingen in Germany, and Dr. Mohan from Chennai in India. So let's start with you, Dr. Birkenfeld. Pre-diabetes and remission. We've only just got used to diabetes and remission. Now you're talking about pre-diabetes and remission. Take us through that.
Yes, of course. So as you just pointed out, we've heard that diabetes remission is very powerful to reduce the complications rate and also the severity of disease. And actually, that was the reason why we thought, well, then we should also look for pre-diabetes remission. And so far, we knew about regression of pre-diabetic glucose levels to normal glucose levels. But pre-diabetes remission goes beyond what has been defined before. And we define pre-diabetes remission as someone with pre-diabetes who goes to normal glucose regulation, normal 2-hour glucose levels in the OGTT, and a normal HbA1c. So that's a quite strict definition, but it is very powerful.
But that implies that you've got to find the people with pre-diabetes in the first place, Dr. Mohan.
Absolutely true. For that matter, even diabetes in its early stages is asymptomatic. And if we wait for people to develop symptoms before we pick up diabetes, even that is too late. Having said that, pre-diabetes is always asymptomatic. And unless we screen and repeatedly screen, because today you can screen somebody, he or she can be normal. After 2 years, they may develop pre-diabetes. So we have to have some kind of a national program in place, which every 2 to 3 years at least screens the population. If you have high risk, meaning your parents have diabetes, you have obesity, you're physically inactive, or you have other features of metabolic syndrome like hypertension, raised lipids, then you should do it more frequently. But even otherwise, we should, after a certain age, after 30, 40 years, people should start their first screening. This can be done as part of a master health checkup. When you go for a master health checkup, an oral glucose tolerance test or at least a fasting and a HbA1c can be done, and this can help to pick up prediabetes.
But many countries would not be able to do that, and you're talking in your presentation about global impact.
Exactly. So I think it's really important to understand which people really have a high risk, to do not tests for nothing in the end, but to the tests when it's needed. And this is something we are working on to really better define which people have a risk and also have a high risk to go from pre-diabetes to diabetes, because this is, of course, also very important. And I think we're getting better and better in that. But I think it should be the screening needs to be on a broader level than we have it right now, because of course it creates costs, but on the other hand it saves costs when we can bring people in pre-diabetes remission, for example.
So screening can always be opportunistic. You know, somebody comes in for something else and, you know, you take the blood pressure and you could do your HbA1c, I guess, at the same time. But actually, very often we know that the people who don't come in for medical care are the people perhaps most at risk. So how could we make sure that those type of people were included?
Considering that virtually no screening is being done at all, the low-hanging fruit would be the opportunistic screening. I would go even one step beyond. A person comes in for a health checkup, at least they've come in for a health checkup. And so today glucose is considered like the fifth vital sign, like temperature, blood pressure, pulse, respiration. And we say that glucose should be the fifth vital sign. When somebody goes to hospital, we check the blood pressure of everyone, isn't it? So similarly, why can't we check for glucose? But I would say you can go even beyond that. The spouse comes in very often. And then you can say, would you like a free checkup? And then you'll be surprised how many people pick up. I can tell you an interesting anecdote of a minister who had come to inaugurate an exhibition which we had organized. And he found a lot of glucometers around. And so I said, why are you having so many? He said, people don't know that they have diabetes. Okay, in that case, you check mine, he said. So we checked his, and he had some horrendous figure. And he said, how can that be true? Your machine must be wrong. Then I said, you pick any meter and we'll do it in that. So he picked one and it was still high. So he said, so you mean to say I have diabetes and I didn't know about it? We said, that's why we're having the exhibition in the first place, and a person like you doesn't know about it. Imagine the person on the street, and therefore now you have to now popularize it. So that's how the thing goes. So you have to start somewhere. Eventually it's not possible to cover everyone, but every drop in the ocean counts. So if you do that, it's good.
So this is really about making sure that policymakers like your minister see the point of this, because it's not about persuading the public, it's about persuading policymakers that this should be part of normal health checks. How are you going to do that? I'm now looking at you.
Yeah, I think it's raising awareness and really showing compelling data, right? That we can, in the end, prevent more severe diseases. And of course, we also need calculations that show that it's cost saving in the end, or at least cost neutral. And this is also something that is done. And I think it will be important then to prioritize screening measures. So maybe we don't have to do all the three measures, so fasting glucose, oral glucose tolerance test, HbA1c at the same time. But if we find, borderline measurements in one, we can do the other ones. And I think this is an awareness that needs to be raised.
So have the health economic costings been done?
It is being done now, for example, for pre-diabetes remission. So we are currently doing it. I think this is a very important piece in the puzzle, of course, to get these things approved also for a broad population.
So maybe that should be a thing for the EASD, to make sure that the health economics for every country are available.
I think the president today in her presidential address did mention two things. One is cost effectiveness, and second is health economics. And third is to bring in the policymakers. Those who decide policy, they have to be on board. Because unless they are on board, we are not going to. But taking it from where Dr. Birkenfeld said, I think we cannot apply a one-size-fits-all for the whole world.
No,
because
every country is different.
In a developed country where you have less number of people, population 4 million, 5 million, 10 million, there the number of people with diabetes are already covered. And then you just have to make this extra step for pre-diabetes. But we're talking about a country which has 100 million people, 200 million people, where even the diabetes is not covered. They're not even picking that up. So pre-diabetes would go further down and to make that cost effective in those countries, or cost saving, is going to be very difficult. So I think each country has to decide. But having said that, the science cannot stop until every country comes on board. So we'll have to, when you speak science, we'll have to say what are the advantages of remission, and then leave it to each country to decide how they want to take it forward.
But I think many governments around the world, I mean, whether it's Global South or very developed countries, all of them, the governments are spooked by the cost of diabetes, and they see it, rising inexorably. So in some ways, you have an open door.
Yeah, I completely agree. And as you may know, the number of people living with diabetes are predicted to rise to 1.5 billion worldwide in the year 2050. So this really shows something needs to be done.
And actually, pre-diabetes does have a ring to it. I think people have got beyond thinking about type 2 as the good diabetes, which was a very, very common misconception amongst the public. So I haven't got the serious diabetes. I've got the type 2, which is not serious. And as we really get more into understanding what the complications of type 2 mean and get that out to the public, they'll see the benefit of pre-diabetes checks much more.
Especially when you consider that for developing the large vessel disease, by which we mean heart attacks, strokes, gangrenes, people at pre-diabetes are almost at the same risk as those with diabetes. The reason why diabetes and prediabetes got divided in the first place was because the eye, the nerve, and the kidney complication of diabetes are more common in those who cross that threshold into the diabetes stage. The pre-diabetes stage, you're not, although you can, a small percentage can develop even those complications, but it's not common. But as far as heart attacks and strokes are concerned, they're just as prone. So I think pre-diabetes, just like we used to say a touch of diabetes for type 2 diabetes, we can't say it's just a touch of diabetes for pre-diabetes. When you get heart attacks, it's not a touch of pre-diabetes. So it has to be taken seriously.
So what an interesting presentation you've got. I do urge you all to have a look at that on EASD virtual learning platform. And it's a great subject. And do please come back to us and tell us how you're getting on.
Thank you.
Thank
you
so
very much.
Thank you.
And there'll be more on EASD TV very soon.